Oh dear, I've already erred, so I'll start again. Good afternoon, everybody, and a very warm welcome to our meeting, and particularly a warm welcome to Tom Abel, our new Chief Executive. Tom, we're very, very pleased to have you with us, and very much looking forward to working with you over the coming months and years. Good to have you here.
Thank you.
Could I ask people, we'll just go around the table and introduce ourselves. I should also say a warm welcome to members of the public attending. Just a very polite reminder that this is a meeting held in public. It's not a public meeting, but good to have you here so that you can see us in our work in taking decisions in the area that we're responsible for. So I'm Mike Thorne, the chair of the Mid and South Essex Integrated Care Board, and I'm passing around this way.
Hello, I'm Claire Hankey, Director of Communications and Partnerships for the Mid and South Essex Integrated Care Board.
Good afternoon, everybody. I'm Giles Thorpe. I'm the Executive Chief Nursing Officer for Mid and South Essex Integrated Care Board.
Good afternoon, everybody. I'm Peter Fairley. I'm Director for Strategy and Performance at Adults at Essex County Council.
Good afternoon. I'm Dr. Anna Davey. I'm the Primary Care Board member.
Good afternoon. I'm Paul Scott. I'm the Mental Health Member and Chief Exec of EPUT.
Matthew Hopkins, Chief Exec of Mid and South Essex FT and a provider member of the board.
Good afternoon. I'm Lucy Whiteman, Chief Executive of Provide Community Interest Company and the Group Chief Nurse.
Hi everyone, Dan Doherty. I'm Alliance Director for Mid Essex for the ICB.
Pam Green, Alliance Director, Basildon, Brentwood and Exec Director for Primary Care.
Good afternoon, Emma Timpson, Associate Director for Health Inequalities and Prevention for the ICB.
Good afternoon, Barry Frostick, Chief Digital and Information Officer for the ICB.
Hiya, Emily Huff, Exec Director of Strategy and Corporate Services at the ICB.
And I'm Cathy Bonney, I'm the Interim Chief People Officer at the ICB.
Good afternoon, Jen Kearton, Chief Finance Officer.
Good afternoon, George Wood, Non-Executive Member, ICB.
Good afternoon, Nehaisa Brown, Non-Executive Member, ICB.
Good afternoon, Shahina Pardan, Associate Non-Executive Member for the ICB.
Good afternoon, Jeffrey Olsen, Associate Non-Executive Member on the ICB.
Mark Balaam, Associate Non-Executive Member for the ICB.
Good afternoon, Joe Fielder, Non-Executive Member of the ICB.
Afternoon, Matt Sweetin, Medical Director for the ICB.
Good afternoon, Stefan Liebrecht here for Mark Harvey, Southend City Council. Thank you.
Thank you. Just before we begin our formal proceedings, we're just going to read a statement about the Lampard inquiry, which has begun this week.
Thanks, Chair. As many of you may be aware, the NHS in Mid and South Essex has been named as a core participant in the ongoing Lampard inquiry. The status reflects the critical role that we play in providing information and insight into issues under investigation. While we remain committed to full transparency and cooperation, it is important to acknowledge that the involvement may have an impact on our staff, on families and carers. As we read out at the inquiry on Tuesday, the ICB would again like to express their deepest sympathy for all those who have lost loved ones and those who have been and remained affected by the matters that this inquiry is examining. We understand that this may cause uncertainty or concern for those within our own organisation and our partner organisations. And I want to assure you that we are taking all necessary steps to support our staff during this time. We'll be providing regular updates to this board, as well as access to resources and guidance for any questions or concerns that may arise. Additionally, we anticipate increased media interest, and you may have seen that already, as the inquiry progresses. It has started, as I said, this week, anticipated for the next few weeks, and then transferring into London. Our communication team is prepared to manage this attention and ensure that our commitment to care and the well-being of our residents remain at the forefront of all discussions. We ask for the board's continued maintain in focus while recognising the sensitivity and the gravity of our involvement in this inquiry. We continue to prioritise transparency, integrity, and the highest standards of care as we navigate this process together. I'll just hand over to Paul Scott, our Chief Executive of EPUT, who has been at the inquiry this week as well.
Thank you, Matt, and to echo your words about the severity and the gravity of the matters being addressed by the inquiry. We take it extremely seriously, and we gave, alongside the other main provider of mental health in Essex, North East London Foundation Trust, we gave our opening statement to the inquiry this week, where we apologised unreservedly for the any failings that have led to the loss of life in the past, and we have committed ourselves to candour and openness in working with the inquiry. My heart also goes out to all the families involved who have fought so hard, and it must be a very difficult time for them to relive that. As you suggested, Matt, Sheila and I, Sheila's the chair of EPUT, and I have spent the week at the inquiry, and we will make sure that 2 board members are present every day at the inquiry so we can hear and be fully participative in the inquiry. So I've got 3 priorities as Chief Exec of EPUT at this time. One is to make sure we serve the inquiry to the fullest extent and make sure we're open and transparent and proactive in providing evidence and information. Second, as you've alluded to, Matt, people are still using our services today. We have 100,000 people under our care at any one time. So maintaining confidence and engagement with patients, their families, our communities, but also our staff is really important. And also what is really important is to continue to drive improvements in mental health care in Essex, which we have embarked on since the formation of this board and will continue to drive through. And I'd welcome the support of the board, the continued support of the board in doing so. Thank you, Chair.
Thank you, and you are assured of that continued support in every way we sensibly can. Thank you. So we will now move on to our agenda, and we've got register of interests there. I don't think there's been any recent updates. We then have some questions from the public. So David Birch has raised a question as to whether effective communication about the ICB's situation with all communities, including South Woodham Ferrers, is a priority across the ICB and its alliances. And Tom, I think you're going to respond to that question.
Yes, I am. Thank you, Chair. And I think this followed something that Tracy, my predecessor, said in terms of the importance of public and patient engagement. And so I think very much so, public and patient engagement has to be the heart of what we do within the ICB and across the ICS more broadly. We are committed to continuing that, both in terms of how we engage across our system in Mid and South Essex, but equally and perhaps more important, at our individual alliances, working with community organisations and patients and communities in each of those areas, and that includes South Woodham Ferrers. We'll continue to work to keep people informed about the challenges that we face across the NHS and the progress that we make, and we'll continue to foster an open and constructive dialogue in terms of addressing patient concerns about our services. Thank you.
Thank you. Paul Osman has raised the question, what is the current proportion of cancers being diagnosed at stages 1 and 2 in Mid and South Essex generally, and how confident are the board that they will be able to meet the national standard of 75% by 2028? And Jen, I think you're going to respond to that one.
I will, thank you, Chair. So currently circa 50, shall I start again? Circa 54% of patients are diagnosed at an early stage in Mid and South Essex. To achieve the long-term plan requirement that 75% of people are diagnosed at an early stage by 2028, the ICB and MSCFT, alongside the Cancer Alliance, plans to support early diagnosis. Our clinical leads and our cancer stewards work to promote pathway and service improvements that will support us to achieve the 75% ask. We are a pilot site for the targeted lung health checks, and this will 137 patients with confirmed lung cancer, around 7% of the total. Cancer screening is an area of focus, and our Macmillan GPs and primary care continue to promote and increase uptake of screening. This helps to identify people at risk at an early stage, which supports early diagnosis. Thank you.
Thank you. Peter Blackman has asked a question. Recognising the widening and increasing transport problems for patients across M and SE, will Mid and South Essex ICB work with South Woodham-Ferrers Health and Social Care Group and other partners to review this issue? And I think, Emily, you're going to respond.
Yeah, thanks, Peter, for your question. We absolutely recognise the importance of supporting patients, carers and their families being able to access health and care services. And we also welcome the work undertaken by MSCFT to restore the shuttle bus to Brimford Hospital and the work of Essex County Council to replace services lost by the closure of the Dart and Arrow public transport service. You noted the strength of feedback around the importance of travel, transport and parking highlighted by those who responded to the public consultation on the future of community services across Mid and South Essex, and we are continuing to consider those responses and what we need to do to respond to the issues raised through the consultation as part of implementation of any potential changes, including those relating to travel and transport. Working in partnership with local authorities, local residents and others will be key to making sure that those implementations plans are developed in the future. We'd also like to highlight that MSC ICB through the Mid Essex Alliance is engaging with the work being led by to consider infrastructure challenges in Malden District, including those relating to travel and transport. And we recognise the importance of good transport links for people attending services. As we're not ultimately responsible for all of that public transport, we'd be very happy to engage in a review undertaken by the South Woodham-Ferrers Health and Social Care Group and working with other partners in this space to improve services where we can. Thanks.
Thank you. So that brings me now to the item 4, which is the approval of minutes of previous part 1 meeting on the 11th of July. Is everyone happy that those minutes are an accurate record? And remind everyone that silence is yes. Thank you. Therefore, I'll get those signed as correct record. In terms of matters arising, does anyone have anything that is not on the agenda? I think we're following most of the themes. Okay, thank you. And in terms of the action log, everything on the action log is either complete or in progress, so things are moving forwards there. So thank you. And that, I think, brings us to our first item today, substantive item, which is the Health Inequalities Update Report and Health Inequalities Statement. Emily.
Thanks, Mike. So the ICB and our partners across the broader integrated care system are doing a lot of work, I would say, in the health inequality space, and we've made a regular commitment to come back to this update on the work that is underway, how we're taking action to try and better understand the health inequalities being experienced by our population, and then reflect on the kind of impact of the work that we have been undertaking. I'd like to thank colleagues at Emma and Sophia I hear who are driving a lot of them. There's a huge amount of contribution from Integrated Care Board, our alliances, our broader system and our integrated care partners as well. And I think we recognise that a lot of what we're doing at the moment reflects on how we're impacting on health outcomes across our population, but we're also going to continue looking at understanding barriers to access and high quality experience for our local population. And that's part of our ongoing conversations with our Population Health Improvement Board that sits across our integrated care partnership. I'm now going to pass over to Emma, as I said, who is driving a lot of this work. So big thanks to her, Sophia, and the broader team. Thanks, Emma.
Thank you. The priorities for the around reducing health inequalities continue to be around delivering around the planning 5 strategic priorities. We utilise the NHS Core 20+ framework, and we particularly focused around prevention of ill health. We continue to make good progress around those areas of priorities. We have a number of proactive programmes in particular clinical areas, which we've been recognised regionally and nationally. Secured some additional funding into those, particularly around cardiovascular disease, respiratory, and some programmes for children and young people. We improve our data insight and the engagement that drives health inequalities programme, and that work is maturing. In terms of restoring inclusive access to services post-COVID, we are working closely with our partners in MSEFT, EPUT Community Collaborative, to ensure improved access to all. In the next 6 months, we anticipate we will undertake further work, looking at how we can improve our experience based on the GP survey results. As Emily said, we're working collaborative with our local authorities, particularly around the broader health and wellbeing, and a priority programme is around reduction in smoking, and we've implemented in-house programmes to support women who are pregnant, and we're starting to see reduction in smoking rates at time of delivery. The Core 20+5 framework, in the paper, it outlines a number of areas where we're seeing improvements. Alliances continue to be the drivers of this work, working collaboratively in partnership to address not only individuals' health, but support them in a holistic way to prevent ill health. In the next 6 months, we will continue to deliver on our action plans, support the re-establishment of the respiratory programme, which will have a health inequalities lens to work that they're doing, and the delivery plans across children and young people. We will see the launch of the EPUT inpatient smoking tobacco dependency programme, which will go live in the next quarter. The risks in terms of delivery to the programme continue to be with regard to capacity to support the programme, but we're working with partners and we continue to focus around a key number of priorities. The annual report, which was the appendix, is the accessible version. The board will have previously seen the published version. Sets out for the previous financial year the work that was undertaken and some of the data and results. We will look to continue to follow and track those key indicators to assess our progress going forward this year, and we'll report again at the end of this financial year. Thank you very much.
Thank you. So are there questions or comments on this paper from anybody? Jeffrey?
Thank you. Thank you for a really good report, and good to see the good work going on. Just 2 things, if I may, around the vaccination for childhood, because I think it's around prevention and trying to get all of these things early. And I'm thinking more around the inequality angle to that. So to what extent are we trying to target these childhood vaccination, for example? So some idea about some assurance how we're trying to do that, and particularly where we're working with, whether we are working with some of these communities or potentially with some of the voluntary and community sector organizations. My second point, Chair, if I may, is I saw the report also around elect waiting lists, and also the fact that Black, Asian, and underrepresented in the list there. The report does point out that we need to focus on finding out, is there some problem around access there? But perhaps something how we are trying to ascertain that and how we are trying to get to grips with that, for example, would be helpful. Some form of outreach, some form of targeting, but it would be helpful to get some idea. Thank you, Chair.
Thank you. In terms of the childhood vaccinations, there is some focus work which is being undertaken presently to identify those children that haven't had their vaccinations, and there's a catch-up programme which is currently being delivered, and we're doing that in partnership with those provider and the local authority around that. There is a bigger piece of work to undertake in terms of that hearts and mindset, and it very much not just around the childhood vaccinations, but it goes across the whole of the vaccination programme, and that is ongoing. We have the research and engagement network, and we have a number of community champions from which are represented from a number of vulnerable groups, and that's a valuable network for us in terms of reaching out to be able to get more insight and understanding to what the barriers are across the prevention programs of work. So that's an ongoing piece, and it includes for elective access as well.
I did read a report, and I can't remember where it was now. Was it Us? Where people had started what they called vaccination parties for children. You see, I know how to have a good time, but that stops it from being a sort of medical model, doesn't it? And it's softened the fear of needles and stuff. I don't know. It might be worth looking in to see if that's because we've in other areas, we during COVID, for example, we had major success, didn't we, in reaching communities that couldn't normally be got to get them COVID up to date. And some more of that kind of work would be tremendous in this space.
We use some health inequalities funding to support an outreach vehicle, and that's going out to populations that don't always engage with health services, and that's offering integrated in conjunction with our local authority partners as well.
Chair, there was a second part to the question, Chair, I think.
In terms of the elective side of things as well, I just want to highlight some of the good work that I've seen going on in MSCFT to better understand the health inequalities on the waiting list and what action can be taken around that. And I join a kind of monthly strategic exec that Matthew holds, and we discussed actually the health inequalities through that meeting. So I would say that there's kind of active work to try and look at both understanding the demographic and challenges on the elective waiting list and the action that we can do on that. And I know that the kind of strategy team works closely as well with our team in the ICB on that. So I might pass over to Matthew to see if he wants to add anything on that. But I think we're taking a kind of regular look at the position across our waiting list, and then trying to explore the actions we can take to address the specific challenges that we're finding.
Yeah, thanks, Chair. And Jeffrey, important question, and perhaps we can share some of the work and maybe get your insights and help with how we might take that forward even further. Because in our development of our sort of next 3 to 5 year plan, clearly health inequalities is going to be featuring significantly as we reduce to people for elective care. So be perhaps if we can pick that up outside of the meeting, Jeffrey, that would be good to get your insights.
Thank you. Shahina.
Thank you for this. One of a national drive at the moment is sort of reducing the complications and mortality in maternity, and the Black community and the Black mothers really have a bad deal by the sounds of it. It's not biological, it is something else. So do we have a handle about what our problem is and what is the progress that's being made on this? Because today on the radio, it says the Black mothers are 4 times likely to die than the Caucasians.
So MSEFT has equity and inequalities action plan in place around this specific issue. There's work being undertaken on a number of different areas. I don't know whether colleagues from the Trust wanted to add anything.
Well, Paul wanted to come in, and then Giles, and then if Matthew, you want to contribute, you'd be welcome to. Paul.
I've got a separate question, Chair, if that's okay.
Shall we just finish that theme, if we can? Giles, were you on that issue?
Yes, absolutely. Thank you for the question, Shahina. So absolutely, outcomes for women and pregnant people from the global majority is an absolute focus of our local maternity and neonatal safety board. We have undertaken with the Trust deep dives both into neonatal mortality and also maternal deaths, where we are not evidencing in our system that we are seeing women from the global majority who have a higher mortality in our system from our deep dive, which is assuring to. However, what we do know is that the experience of women and pregnant people from the global majority is different to those who identify as naturally white, and therefore our Maternity and Neonatal Voices Partnership are working with the Trust so that those voices can be heard in terms of anxiety when they are going through labour. So that any services that are being provided are culturally sensitive, which is the most important thing, and so that those women feel that their voices are being heard.
Thank you. Paul.
Thank you, Chair, and thank you for the work. It's a really comprehensive report, isn't it, Emma? Thank you. And that really showcases all of the work that's going on across a wide range of inequalities throughout the system, and I'm really pleased that you referenced the work of local authorities and the ICP as well, because we know the causes of health inequalities as well are fundamental to this. There's a huge amount of evidence-based input way, etc. will and I can't always hear measuring the impact on outcomes, so mortality, comorbidities, prescribing, whatever it might be. Is that something that we have planned for the future?
Yeah, that is something that we have an outcomes framework that has been established with a number of health inequalities indicators that we will be tracking. Our business intelligence provider is supporting us in pulling through that data. It's an area that we need to do more on, and it's work in progress. I think compared to other systems, we're in sort of a similar position to others, but I would see us making sort of a step change in the next 6 months around that.
Thank you. Well, I think now I'm going to have to. Oh, I'm sorry. Okay, you slipped in under the wire then, Lucy, and then I must move us on.
Thank you. It's a very quick one, but it's to a similar point, actually. I recognise that throughout this, one of the challenges is the deficit within the intelligence that we've got, both the completeness and the accuracy of the data that we're collecting, and we can all collectively commit to improving that within our organisations. And I know Provide is one of those organisations that certainly needs to improve that. But also I wonder if we lean into the public health capacity, both locally and regionally, in order to support some of our analyses, particularly with regards to outcomes.
Seems like a good idea, particularly in times of shortened resources. We should maximise from every, where we can live alongside other information, shouldn't we? So I'll give you last word, Emily. We're asked to ratify this statement and report. Are we happy so to do? So that's secured, Emily.
Yeah, I mean, just to kind of comment on what you're saying, Lucy. The things over the last few months, 6 months or so, certainly since I've been in the ICB, that's really encouraging is how strongly the public health leaders across the system are coming together, and we are working in partnership with them. And just to kind of highlight a conversation that Emma's currently facilitating across our kind of public health, data and insight alliances as part of a kind of task and finish from our Population Health Improvement Board to look at where are we at, where do we want to get to, measure progress on that using the dashboard that Emma's referenced that we're trying to develop. So this is a point in time update, and I think we've committed to bringing 2 a year to this board. So we'll look forward to providing hopefully good progress on all of this in the next 6 months as well.
Thank you very much, Emma, and to others, all the work that's gone into this and those people running these really quite exciting and enterprising projects. Thank you very much indeed. So I need to move us on now for time management purposes. The next item is system response to the NHS letter on corridor care. This was something that came out of NHS England in response to a television programme which highlighted a particular case where there were people who were spending a very long time sitting in hospital corridors because there weren't beds available for them to get into to get the care they needed. And NHS England was seeking to know the position from each of the 42 integrated care boards and so on. And we've got a response here. And I think, Andrew, you've come along to talk to this, is that right?
Yeah, sorry, Andrew.
On my microphone on. I don't. Do you want to introduce by
well,
introduction, Emily? Then I'm happy to ask.
Not too much more to add other than Mike. Tracy asked for an update on this at her last meeting, and hopefully the detail Andrew will talk us through demonstrates the collective action that we're taking across the system and provides the board with assurance on the breadth of activity that's underway to try and ensure we minimise and hopefully in time are able to eradicate the use of corridor care across MSCFT. So thanks to Sam, who's unable to be here today, and Andrew for all the work that they're doing that sits behind this with colleagues, as well as the kind of detail that's in the paper. So thanks, Andrew. So I think you have to, yeah.
Thank you, Emily. Thanks for reminding me to put my microphone on. I think, Chair, it's very clear to members of the public and the board that we should say that we cannot wholly eliminate corridor care, and I'll explain why, but we would, where I think we're very clear is what we're doing to work towards its elimination, and secondly, to make sure that if it does occur, that it's safe and it's for limited time periods. And I really do that in sort of 3 parts of the paper. The first half, which has been very much written in conjunction with Sam Goldberg, who works for the system, is all of the measures we take as a system to manage demand on a daily basis, because the better we manage demand, the less risk there is of corridor care. And you can see that from everything, the 111 pilots to the unscheduled care hub. We're hoping to get some confirmation pretty soon that we can get the unscheduled care hub operating on a more full basis again for this winter, as we did last year, because that has a significant impact on helping us manage demand. Then in the document, again, I'm happy to take any questions. It shows what we're doing as a hospital to make sure there's absolute complete focus on improving flow throughout the hospitals. And we all know that around this table, that since the peak of 2022, we're probably getting on for about 240 less beds in the hospital than we had, due to an improvement of about 1 day length of stay, due to both what the hospital has done to manage what we call our safer ward care process, what we call our red to green. When a patient's having active treatment is moving through their pathway, a red day is when nothing's happening. So we are minimising the number of red days on our wards and maximise the number of green days, all of which improves the input from our professional staff to manage the patient's length of stay for a shorter stay in hospital. And then the big issues we had in 2022 to date is obviously then the discharge of patients who require complex discharge, and that is in a significantly better place, as we all know, than was the case. So that then reduces the risk of hospitals becoming congested, which is where corridor care may come from. The reason I say, Chair, in all of the action we're taking, is I'm really going to highlight 2 remaining risks that we must attend to as a system, is that we are using the continuous flow model, because we have made offload of ambulances the priority in our UEC pathway. So for a period, and we set time limits of between 1 and 3 hours, if we do find we have a surge of ambulances to our A&Es, and at that moment in time, and it's not all the time, it's just when required, your resuscitation, your major cubicles may all be full, and you're planning your next move of patients to leave A&E. Rather than have patients left in the ambulance, we'll make sure we use a corridor space designated in each of our EDs to allow the offload of ambulances to occur. That should be for a limited period of time as we then move them through to our major cubicles. And they are staff allocated to those areas, so these patients are not left alone in that period. And I'm pleased to say we have had one day this week use the offload corridor area in Southend, but overall, compared to where we were, Chair, it's used a lot less. The second reason is when we find on occasions, and it's only particularly occurring at Basildon Hospital, it's not happening at Chelmsford, it's not happening at Southend, that due to flow pressures, and as we all know from our bed model in Basildon, where we haven't quite got a complete match between our bed capacity and is that an overnight placement of a patient in an extra space on a ward, and in an extreme circumstance that may be in the corridor of the ward, but that is on a very rare occasion, is what we call our full capacity protocol is implemented, and that's when it's occurred. And you can see on page 101 of your papers the number of times in a period that a patient has been in an extra bed area on a ward. That's not an escalation ward, that's when we open up a whole extra area and staff it. It's an extra area on a ward where the patient may be accommodated, and that's almost exclusively at Basildon Hospital. So there does remain work for us to do as a system to work with our partners and with Basildon Hospital to try and make sure we can get a better match between bed capacity and demand. And to that end, we're working on a pilot with NELFT as we speak for speedier discharge of patients. And I think, Chair, the final risk I had highlighted, and Paul knows this from the unplanned care portfolio board that Paul and I attend, we still require to make our winter planning work a minimum of 65, probably more like 100 bed improvement for this winter if we're to avoid open up escalation beds, which obviously is the financial plan we would wish to avoid. Then obviously there's a risk of that mismatch in demand capacity. That's not to say we use corridor care as a solution to that problem. We would use it through escalation beds if required. So I want to assure the board that we are bearing down hard. We're going to minimise it. The patients, if it occurs, are safe. It is rare. It is partly used for the continuous flow to make sure we can make a priority ambulances. And it is particularly Basildon where we need to do work to avoid that small risk of overnight excess of capacity. And we have this risk for winter. We would use escalation beds if we needed to, but I'd hope we can work with our community partners to improve our discharge to make the bed model work. I'll stop there, Chair.
Thank you. And that does add some background to the paper. I mean, maybe this is two professionals speaking the same language, but in the spirit, you'll see further on the agenda, our feedback from the region as an ICB was we were to continue to work in really collaborative, friendly partnership with our hospital, but to be more demanding. And in that spirit, when I read this paper, it describes for me a list of activities we're doing that are pertinent to the question, but I couldn't, and in the table, as a mathematician, I couldn't see what the table was telling me because it doesn't tell me, you know, what is the worst case, because they look like they're the weekly snapshots. So, yeah, so obviously within a week, the peak could have been, you know, 1,000 and on one day, and then the remaining 6 days 0. I'm slightly exaggerating, but you see what I mean. So this table didn't really seem to enable me to answer the question. I mean, first of all, do you feel that, you know, where do you feel you sit as a hospital in comparison with others on the issue of, you know, people in corridors? Are we up on the average? Is our problems because, Andrew, what you were saying about Basildon and, you know, our lack of beds, are we therefore more challenged than other hospitals? Trying to get just literally an honest feel for where we are. And I couldn't really get it. I got the list of activity, which is very reassuring. Thank you. I couldn't answer the exam question, which I think was, you know, are we good, bad, or indifferent at this?
So the recent research actually, which is published in the Health Service Journal, that undertaken shows that as the use of the continuous flow model Mid and South Essex is one of the better hospitals where there's been a positive effect on length of stay and a positive effect on ambulance offload. And as you know, we, in terms of ambulance offload, which varies somewhere between an average under 30 minutes of 90% of all ambulances under 30 minutes, Chair, we average somewhere between 17 and 22 minutes. We rank as one of the best in the region. And often on many days we're the best in the region. And that has been directly as a result of the continuous flow model being introduced.
But just so help me with the exam question
Yes.
then. That's about ambulance
So that's
being
where
dealt
you
with.
may
What
use
about
a
the corridor care issue?
So that may mean for a period of 1 to 3 hours in an A&E, you could have patients in a designated area, having the A&E departments in Southend and Basildon, where there's a corridor area where we will allocate a nurse so the patients are safe to offload the ambulance while we're waiting to decongest the ED. If busy, because often, particularly at Southend, we may find we could have 6 or 7 ambulances all come at once, and they've got to be offloaded, and we still want to offload quickly. So that could result in corridor care, Chair, and I think we've seen a positive, on balance of risk, a positive result doing so. Your point is well made on the cumulative numbers, which are weekly totals of FCEPs, full capacity protocol, patients in extra spaces on wards, not always a corridor, and that's almost all Basildon in that period. And the worst occasions, Chair, will be up to 15 patients of a night time. Could be in a absolute worst case in a bay in an area near the nurses' station in a corridor, but normally within a bed bay or a converted room. And that period in June, I think that we had up to 14 on about 3 nights in succession. So it's a kind of a peak, and then it's not a continuous everyday thing. And that's when you've got a very sharp mismatch between demand capacity, discharge on the day versus demand, Chair.
Yeah, thank you. I mean, that helps us understand, where things are for you, which is challenging. Thank you.
It is, hence my point on the point for us to work on is because we can measure, we can provide as many information as statistics as the ICB require, Chair, but it's the traction on our winter planning with the use of our committee facilities referred to in the paper, as Paul is aware, because if we can get our discharge in to match our demand on an everyday basis, the problem disappears, doesn't it, in a nutshell?
Thank you. Anna.
Thank you, Mike. I was just wondering if this is a metric that we can continue to see in the board reports over the winter, please.
We do collect it on a daily basis, Chair, so we can supply that. Because I do think, I agree with Anna, it's a very good metric. We are very concerned whenever we see one patient in an extra bed space as a measure of whether we're in balance between demand and capacity.
Giles?
Thanks, Chair. I think just to inform the board as well, we were given information on Wednesday that the national team are now developing a dynamic risk assessment in relation to corridor care. An offer was put forward to the region, and I've put this system forward as to be one of the early adopters and to test the risk assessment to see if it works. And this will provide further assurance from a clinical perspective that we're managing clinical risk in a safe way as we head into the winter period.
Thank you. George?
Thanks, Chair. Yeah, really helpful report, Andrea. I guess the piece that I was trying to triangulate was the length of stay and stranded patients, to try and get a sense of, as we move into winter, have we got enough beds in the community to keep that flow going? And it was really the forecasting element of where we are today with lengths of stay, stranded patients, and what requirements you need to have outside in the community to get these patients flowed through as quickly as possible to minimise the corridor care. And the second point was really on the letter from NHS. It says regular non-executive director safety walkabouts. Is that something that you need any help with in terms of non-executives going around Field or Basildon or Southend? Because I'm more than happy to do a walkabout.
I don't think we say no to that. I'm just talking to Matthew, because our own non-executives have recommenced their visiting programme.
Okay.
But I think we could do that as we have, some of Giles' colleagues come around and visit our sites. We would not say no, George.
Okay.
I think your specific question is what we're targeting. Perhaps like Paul just to add is the utilisation of our virtual wards, our urgent care community response teams. what we are doing with our bridging service, and importantly, what we can do with the intermediate care length of stay to try and make sure that can align as best with our assumptions. Because roughly speaking, so we can make the clear distinction, there are patients who stay with us for a long length of time who are not yet medically fit, and they will still be in our stranded patient group that we want just to keep an eye on to make sure that their care is delivered. And we're working together, say, for example, patients with brain injury, to see what we can do to try and speed up pathways for discharge. But there are patients who are ready for discharge, who on every average day, we probably across the 3 hospitals have about 150 patients whom we are trying to press, many of whom will become optimized, as we call it, and discharged within 1 or 2 days. Others, it might take longer. So 1 or 2 in our hospital, I think, are now in excess of getting on for 80 or 90 days. But there'll be a very small number within that for a whole reason of complex reasons. So that's the group of patients that Paul and I and others will want to work hard on to make sure we minimise the stay in hospital, maximise the use of virtual wards or intermediate care beds or other community placements, so that we can manage this flow pressure. The pilot I mentioned with NELF, we're also trying to work with our community nursing college to see whether some patients can go back home without complex care package, because hospital doctors and nurses may not always be willing to take the same risk as a community nurse might in terms of discharge. So we are encouraging that level of joint working as well. I don't know whether Paul wants to add anything to what I've said.
Yeah, I mean, George, I can briefly say that. So I chair a system flow group that tries to bring all aspects of the brackets system together, all lined up to deliver the same thing. And that group is the issues that Andrew describes. We've been very focused deliberately, and we're very focused on making sure people are getting out of hospital as quickly as possible. As Andrew's alluded to, some really good work gone on with the UCRT, with virtual wards and community utilisation as well, community bed utilisation. The plan for the winter that Andrew's mentioned a few times is now a system plan, and everyone's signed up to deliver it. Our focus now is on delivery, and we'll be monitoring that every month from now.
There's enough beds in the community. I guess that was part of my question. So well, we're satisfied that...
So that there's enough beds if we reduce the length of stay in the community, and that's the key piece of work that we're doing with the collaborative.
Thank you.
That's clear, thank you. Last question and word on this topic then to Joe.
Yeah, thanks very much. Very helpful report. I'm just wondering if we could just spend a few minutes talking about the front end, because flow through the hospital and discharge from the hospital, critically important. I'm also interested in not admitting in the first place, and if there's initiatives that are being taken, particularly with community providers, to just not admit so many, so reduce demand at the front door, so to speak. If we could, Andrew, thanks.
If I introduce, I will definitely look to Paul to add, and maybe even Tom. So the main tools of the front door, and obviously with Anna and other GP colleagues in the room, a lot starts at the GP practice as well, doesn't it, to make sure that you've got all of our interventions in place, particularly those patients with chronic conditions, so that we can avoid them getting exacerbations and come into hospital. So you've got that clear foundation in primary care, but the main levers we use on the urgent care pathway when someone's starting to go on an urgent journey will be obviously to try and avoid just a straight default attendance to A&E, will be the urgent community response team, who on average I think are intervening, Paul, now to something like 40 or so patient interventions per day that are all probably preventing an otherwise attendance to A&E. They have a caseload that is fresh every day in terms of responding with the ambulance service to respond to the demand. We see that on our system calls. Every day we can track the demand. We've got our own same-day emergency care services that general practice will use, where they can divert from the extra opinion to a consultant physician at our front doors. We have Essex, as we call them, all 3 sites, so that we can again avoid A&E attendances, and particularly at Southend, we've taken some demand off A&E these last few months, which has helped performance by expansion of the ESDEC services at Southend. And then the one where Tom, I just wondered whether you've got any more latest information, or Emily, that I haven't got, is we had the pilot last winter. I think we've now have secured resourcing from the region to open again the urgent care coordination hub, where essentially some clinicians on designated sessions will join the ambulance service and our community urgent care response team to field all calls directly from 111 or from the CAS via the ambulance service to filter a range of community interventions that might be from a whole variety of things, or just a simple, please don't panic, this patient doesn't need to come to A&E type conversation. We saw that probably choke off when it was working well last winter, maybe 14, 15, otherwise what would be in admissions to ED. The one area I'd like to do more with is with our ambulance colleagues, because I think, Tom, you and I would agree, with Tom's old hat on, there's probably still some more interventions we could take place with our ambulance colleagues when they go straight to routes to make sure they are using all of those diversionary options.
Emily wanted to come in, and then I will need to start moving us on.
Yeah, thanks. I think, Andrew's talked through the the unscheduled care coordination hub, which we are on the verge of getting the confirmation for, if we've not already had it, for continued funding for that. I think the other thing to mention is that we have a system coordination centre that works through all of our partners, and there's a daily phone call at 10 a.m. every day, which brings all of our system partners together to reflect on where we're at, where the challenges are, what's happening in the community. Our local government colleagues participate in that to look at what beds we've got in the community outside the NHS as well as inside the NHS. Are we maximising the use of our virtual wards? How are we doing on our kind of ambulance performance for that day, as well as our patient transport, to make sure that we're kind of unblocking the back end. So I would say that Andrew's kindly led a lot of this conversation, but there was a system contribution to this, a lot of which is focused both on the front and the back end. And I would say that's proving to be quite successful. 10 a.m. call every day, but if required, follow up. And our SCC runs from 8 a.m. to 6 p.m. every day. And so they're checking in all throughout the day with all of our system partners. So I think that kind of point around how much we can do on our front end. And the other thing at the moment that we're carefully monitoring, primary care is actively engaging in a lot of that, given the kind of collective action at the moment. So we're kind of trying to track whether or not that's going to have an additional pressure.
Thank you. I'm giving Tom the very last. He can move seamlessly on to his chief executive's report. Tom.
Thanks. Thank you, Mike. So I think, yes, so this could be an area of absolute focus for us across the system, given the risk associated around every winter within the NHS. I think the other thing that came out, I think, last week was some guidance around single points of access from NHS England. And so we have a lot of that covered through the unscheduled care coordination hubs. However, I think one of the key things within there that we're going to need to look at is how do we open up access to the unscheduled care coordination hubs from more areas, particularly care homes, and so them being the first port of call, as opposed to, say, the ambulance service or as opposed to the emergency department. So that, alongside the resources which should allow us to increase medical input into the UCCH, I think will be incredibly helpful. But we are going to need to motor, obviously, because, well, it's feeling a bit like winter now already, isn't it? So, yes, so I think something we will need to come back to and continue to monitor. And I think the suggestion from Anna in terms of this is something that we keep monitoring through these meetings would be helpful. If I move on to my report, so this is my first report as chief exec. I think there's 4 things I wanted to just kind of draw to. So I think the first one of those is clearly, I think, the most significant development since the last time we met is the financial position of the system and the deterioration that we've seen. That is something that we spoke about in seminar this morning and will require a lot of focus and drive. I think that will form a kind of a 2-part kind of, or 2 prongs of attack. So the first phase of that is clearly the work we need to do in year to try and stabilize the financial position. And given how far through the year we are, that is going to be focusing on grip and control measures and actions across all partners within the system. And then phase 2, which needs to run in parallel, is the development of the medium-term sustainability plan. So what are the changes we're going to need to see in the way we deliver service in Mid and South Essex to get them to a more sustainable place, both from a money, access, quality perspective. Secondly, we've obviously had the Darcy report has come out this morning. I haven't read all 163 pages, although
nothing better to do.
So I think it's quite a hard-hitting report, just having read the executive summary, as I'm sure many board members have. I think it is something we're going to want to look at in slower time in terms of looking at our specific response to that. But I think some of the themes that are coming through that report around some of the solutions very neatly, I think, fit into what we may want to do in the medium term. So things such as the empowerment of patients, the engagement of staff, the shift of care closer to home, simplifying the way we deliver care, greater tilt towards technology, etc. I think all speak to things that we've already spoken about, which is helpful, and all power to our arm. Thirdly, the community services consultation. We have received significant feedback on the proposals around community services, and I've been working with partners to try and clarify the best way forward on that based on the feedback we received. We are, I think, can say we're nearing a conclusion on that, and we hope to be able to share some next steps next week on that matter. And then finally, I've also shared the annual assessment from NHS England of the ICB, and we're working through our response to that at the moment, particularly in those areas where NHS England has identified opportunities for improvement. I'll leave it there, Mike, and if anybody's got any questions, I'm happy to take them.
Yeah, any questions or comment on Tom's? Oh, yes, sorry, Neha.
Thank you, Tom, and well done for your first report. You feel the challenge. Just to get a measure of feasibility, if you like, in all of this. If you look at the numbers, and of course we have the targets, they're difficult, we're in a difficult position, we understand that. But, looking through the numbers for RTTs and so on, and elective care. So we currently have around 2,000 patients waiting above for 65 plus weeks. The target is 0 by the end of this month. So it's just kind of as ourselves, asking us as a system, how much of this, where are we doing that feasibility check? And of course, getting to that, reading the whole report.
So I think one of the things one of the areas of development I think that we need to work on, I think, across the system is around how do our assurance processes operate more generally. And so I think there are plans in place, and Matthew might want to respond to the specific point in terms of the 65-week waiters, but making sure that we can evidence consistently to this board and to our stakeholders that the plans are in place, we are delivering to trajectory, and if we're not, what therefore are we doing about it? And so I think that is going on at the moment, but it's probably not as visible as we would all like it to be. And so that's definitely an area of development that I've started to talk to the ICB team about how do we bring that about. I don't know, Matthew, you want to talk about the 65-week wages?
Yeah, very happy to. And I think partly, this is perhaps a consequence of the tiering, national tiering system, and the way in which, in many ways, that reporting mechanism every fortnight for tier 1, whilst ICB colleagues are present, it almost bypasses the oversight that rightly the ICB would want to have in place. The region confirmed to me on Tuesday evening they were confident, given our clearance rate, as in the number of patients we're treating each week, that bar a small number of patients that have chosen to not have their treatment in September, we will be able to deliver the expectation of 6 weeks by the end of this month.
I wanted to speak highly in support. This is one area where our hospital has shown itself repeatedly able to pick up something like that and deliver. I'm very grateful, albeit sometimes at increased cost because we've got money as an issue, but let's recognise achievement where it is and say thank you for that. So for me, that's an area where promises have been delivered more often than not, actually. Shahina?
Yeah, and just to follow that up, I follow ophthalmology now, which is amazing, really.
Given that size. Joe, last word, and then I'm moving us on.
Yeah, just a very quick point, Matthew. I wonder to what extent, when we've got waiters at 52 weeks and 65 weeks, we could do with some cleansing as well, because I can remember working through in completely different world, sales prospects, and once they're over, 28 weeks old or something, they're half of them aren't rude in the first place. I don't know if that's relevant.
Yeah, very much so, and you'll know from a former life that the importance of validation of the waiting list is an ongoing and regular exercise that our operational teams within the Acute Trust, the management of our patients, and there are strict rules so that patients aren't removed unnecessarily. We have a tight access policy to ensure that patients come first in that regard, and we inevitably will into next year. I mean, it's important to note, from my perspective, and I'm sure the board's perspective, waiting 65 weeks, 52 weeks for a first outpatient appointment is a very long time when you're in pain and discomfort. So our board within the Acute Trust is very clear that we're looking well beyond the 65 target and the 52-week target to say, how do we organise ourselves in order to make sure our waiting times are as short as the resources available will allow.
Thank you. And now, again, in terms of time management, need to move us on to quality report.
To highlight four key issues following the quality committee, two quality committees that have been held since the last board. So the deep dive that was had into our special educational needs and disability system across Mid and South Essex, with some particular areas of focus on improving how we're communicating service availability to families and recognising that there are significant challenges within the system due to increased demand, increased complexity of presentations versus limited capacity both across health and social care. And there is an ongoing plan of work underway, and my thanks to partners in the local authorities who are helping us to minimise the backlog as quickly as possible and also ensure that families are supported whilst waiting for their assessments. I've also provided an update in relation to the Babies, Children and Young People programme of work through our commissioning team, and it is important to note that we do hold a statutory function to ensure oversight of the BCYP programme in our system. So it's important that the board are cited on the key programmes of work, and also in reference to the work around health inequalities and particularly the long-term conditions oversight and provision with a focus on CYP core 20+5 conditions. A matter that has arisen at the most recent quality committee is in relation to initial health assessments for looked after children, which is an ongoing safeguarding concern that we hold across all three local authorities, which is that we have a significant backlog in being able to undertake initial health assessments due to a lack of paediatric consultant capacity. It is important that the board is aware that under statute and regulation 7 of the care planning, placement and case review regulations, it does state that initial health assessments must be completed by a registered medical practitioner. This is something which we have escalated through to region, and I will be working with the Chief Nursing Officer region to put forward a proposal to see if there is a way in which we can work around the regulation, recognising that another ICB has made an executive decision to do so. However, at the current time, we will continue to have a backlog of children who require an initial health assessment until we are able to negotiate a change in the rules. And to note that this change is supported by both the Royal Colleges of Nursing and the Royal College of Paediatrics and Child Health. In relation to maternity services, very, very pleased to note that the notice of proposal to remove the Section 31 conditions on the licence of maternity services at Basildon has been received, and that has now progressed, which is positive to note. And also that the re-inspection of Broomfield Hospital maternity services concluded with there being no immediate safety concerns, and the local maternity and neonatal safety board will work with the trust once we have received the formal report for factual accuracy. And the final point, just being, as we mentioned earlier, was obviously in receiving the feedback from the ethnic community leads of the Maternity and Neonatal Voices Partnership, which again are focused on EDI for the populations that we serve, and the continued work to ensure culturally sensitive services are in place. Thank you, Chair.
Thank you. Any questions or comments on the quality report from anyone? No? Thank you very much, and thank you. So we now move on to finance and performance report. Jen.
Thank you, Chair. So the board's in receipt of our month 4 finance and performance report. I will take the report as read, but just to draw out a couple of the key points, and actually in the board does link into the performance aspect. Obviously, Tom's chief executive report touches on the I&I work that we're having and the increased oversight that we've got with NHS England external partners to support with the financial position. However, just to note, at month 4, the ICB has also declared a year-to-date variance that's adverse to the plan that it was hoping to have delivered at month 4. That is largely the result of the materialising of the risk that we have been reporting to the board so far this year around the all-age continuing care space. There is additional work going on in this area. The Finance and Performance Committee is due to receive a deep dive report next month. The outcome of that we'll bring forward to the board. However, we have an intensified focus here, and we've also been speaking to our regional colleagues for support in this area and with other ICBs that are also facing the same pressures. The small forecast outturn variance will not be there at month 5. That is to do with some unexpected costs which we have been able to manage, but month 5 position, which is currently going through scrutiny at the moment. In terms of the overall system position, again, and you'll note from Tom's report earlier, we are showing a year-to-date adverse variance, again, where we were hoping to be at this stage in the year against our agreed deficit plan of 96 million. That has led to additional oversight from NHS England colleagues, and the ICB is working very closely with them to start to support interventions that will get us back on track for this financial year. Both Trust and EPIRT, so MSCFT and EPIRT ourselves, have been involved in that work and continue to work collaboratively to ensure that we do have a good understanding, to ensure that we are taking collective action to we can deliver our control total this financial year. I will take a pause there before just touching on the performance aspects, if I can. Any questions?
Thank you. I mean, can I ask perhaps the 3 lead system chief executives to sort of give us a kind of, as far as they can, a kind of candid view about where they think things are at the moment, perhaps starting with Tom, because our exposure was potentially a very large amount of money against our budget, and we've got to get on top of that. And what's your feeling about our capability, capacity to get there and get that sorted within the time that we are expected to, which is this financial year, isn't it? And I'd be interested in the answer to the same exam question from Matthew and Paul.
Yeah, of course. So in terms of the ICB position, the key risk is in all age continuing care. And that is for, I think, probably to kind of the one key factor is in terms of we are seeing an unexpected level of growth in terms of the demand for that service, and also we're seeing some growth in terms of the cost of packages. So in terms of the steps that we're taking in order to address that, me and Giles have been working together in terms of steps we can take to strengthen the leadership of the team. We hope to have that in place by the end of this month. So it's just going through triple lock. So that will be in place. Equally, also, there's significant opportunity to work with local authority partners on brokerage in this space. And so Becky, who's unfortunately not able to be here today, has been leading a piece of work for us in terms of exploring the opportunities for that. I think we're going to shortly look to undertake a pilot with Southend around brokerage and joining up some of our contracting activities, because we're buying from the same providers, but quite often we within the ICB are paying more than local authorities are, which isn't helpful for anybody. So there's something to go at, but it is a risk, and we know it is a risk that all ICBs in the east of England are currently seeing, is this growth and demand for continuing healthcare. So I have a moderate level of confidence at the moment, Mike. I think there's lots to go at, but we're going to need to keep a really close eye on it.
Okay, Stefan, Peter, anything you want to pirouette on that? Okay.
Because that's the other effect of it.
Tom's outlined the opportunity. We're fully in agreement from the local authority, and those discussions are starting to take place.
Thank you. Matthew?
Yeah, thank you, Chair. So in similar vein to Tom, I think there's opportunities. I think the additional support that we've been given has landed well, and is starting to progress both the acceleration of our existing plan with additional capacity, but also identification of other mostly transactional schemes that will help to put the brakes on spend, which essentially is what is required. I think the hill is steep, but certainly I'm confident my leadership team and my board are fully behind it. I think parts of the organisation are also very clear on what's expected. As ever, when there's a turnaround environment, you do get a little bit of pushback from certain groups of staff, which we're in the process of managing. But I think it's a steep hill, and I think there's an element of risk associated with this. And obviously, as we've touched on, our plan is based on not opening any escalation beds in winter. So there's an element of we need help from everyone to deliver the expectation, along with the things that we allow.
And absolutely, I'm sure everyone is up for doing whatever everyone can. Of course, absolutely every single part of the system is under financial strictures, including our local authority partners and how. Thank you. Paul?
Yes, similar. So our plan was based upon addressing the very high usage of bank and agency staff to support our clinical services. And to do that, we were going to implement a new clinical and workforce model that was progressive, that should have a better chance of needing less temporary staff, and to ensure people were able to get home into their communities quicker. There's two risks to that. One is timing. And the sort of the delay with region around agreeing financial plans, plus the stickiness in the recruitment market, means we're a bit off track at this stage, but that's the area I'm most attentive to at the moment. Is these plans and changes need clinical practice to change, and to change clinical practice under the scrutiny of an inquiry is difficult for colleagues, and I'm working very closely with colleagues to make sure that happens. At this stage, the board, the leadership team, our clinicians are all behind it, and I remain confident we'll deliver.
Thank you. And Jen, you're going to finish performance, and then I'll invite broader questions or comments.
Sorry, Mike. So again, to take the report as read, we've heard a lot this afternoon about urgent emergency performance and the work that we're doing collectively. So whilst we are currently off our operational plan, we recognise all the work that's happening in system flow around our unscheduled care coordination hubs and maximising the use of capacity outside of the hospital to support flow through the hospital, and indeed the ambulance handovers, as we've discussed already. As we move through the reports, overall performance in the diagnostic space is where we anticipated to be broadly. However, we have got some challenged modalities there that we continue to work through. And you'll see that it's a very detailed report. I would just add to Tom's comment earlier that we are continuing to work with the Finance and Performance Committee as well about how we refine the level of detail that's included in here, as well as gain the assurances that we can provide to the board. So moving through the reports. In terms of the RTT and cancer, so just to pick up your point earlier, Neha, the 2,000 that you mentioned in terms of the 65 weeks is a June figure. And you'll be able to see from the charts that that is steadily starting to come down. So hopefully that gives you some assurance rather than it feeling like it's September and we're 3 weeks away. So probably just quite helpful to note that as well. And the tiering, I think, does come out in the cancer elements, and that is something we need to draw the visibility through here. We'll just finally add that our mental health metrics that we are measured against in terms of the constitutional standards, we have got sustainable achievement in that space at the moment.
Thank you. So invite comments. Just Matthew, when will all three of our community diagnostic centres come online? What's the sort of date? When does that happen?
So if I get this right, work on the Braintree one has started. That should be early 2026. Work on the Thurrock one has started. That should be, originally it was intended in December. I think that's going to be early 2026 as well. And the arrangements to get the work moving at Pitsea have been approved by our board this morning.
Okay, so I mean,
I don't know what the end date for that is. Colleagues might know, but that's the one that's going to be one of the biggest community diagnostic centres in England.
Okay, so I mean they will make a big difference when they come
massive
on,
difference
on the stream, won't they?
And Mike, going back. Somebody's turned me off. Going back to the earlier comment about achieving standards towards 2028, that's why these diagnostic capacity coming online are so important in the next couple of years, because that will help both cancer diagnosis but general routine diagnosis, particularly with 8 endoscopy rooms.
Thank you. I'm against time, but any further questions? Joe?
A bit of an appeal, actually, with Paul and you, Matthew, present. We are working very hard in our Finance and Performance Committee to understand run rate better and where we can get to what I refer to as the inflection point. So have confidence and assurance that we've turned the corner. So it's just an appeal, really, to be receptive when we come knocking on that one. I'm sure we've knocked on the door already, but thank you.
That was a nod in the affirmative. George?
Yeah, very quickly. If there's any winter support money available, do we know where we would be targeting it? I know there's a lot more strain on the money this year, but normally money is made available for winter support.
I have been told unequivocally that's not going to happen this year.
That's
So we aren't planning for any utilisation of further resource. The message from the national team is very clear that all the funds are out there this financial year. So our focus is on how we can ensure we take the operational actions we need to avoid needing further funds.
Well, there's a challenging point to end that particular discussion on, isn't there? Because we've relied on that year after year. Thank you. I now move on then to primary care report.
Thank you. I'll equally take the paper as read. This is a report designed to give an update on primary care as well as alliances, given the proximity of the two and the activities they do together. I'll invite Anna Davey, our board representative, primary care, to make comment afterwards, and obviously Dan as another one of our alliance directors here today. So most notably, since the last report, there has been a national agreement around collective action, which was referenced earlier in the meeting from general practice. And it's our responsibility as the delegated commissioner for primary care to evaluate the impact of that across the wider system and support any actions. To date, it hasn't manifested itself as a big issue, but we are aware that there's been a further appeal to evaluate that and to demonstrate the impact of workload across primary care. So we must diligently do that across all the decision making that we are undertaking. The findings of recent activities around dental work was presented to our integrated care partnership yesterday with care homes, and a wonderful piece of work that's been done to mitigate health inequalities for care home residents and look at improving the experience of our dental hygiene, increasing their scope of practice, which is leading the way in dental delivery, which we're very proud to report on within this report. We've included, as per the request of the action log previously, around estates. So there has been some changes in estate regulations around primary care. However, they haven't ultimately unlocked our ability to build premises because of the complexity between capital, between district valuers, and the ownership arrangements of primary care estate. However, it does give us a little bit more flexibility, and we seek to work with local authority colleagues around Section 106 monies that are attributed to health, and building and development comes in to support health infrastructure. But there is note within the paper around the changes, and if anybody's got any questions, we can answer those. The activities around digital infrastructure within primary care continue to improve. We've got good take-up around our cloud-based telephony, as well as total triage. We've invested as an executive board national monies into triage support tools that are digital, and there's been good take-up from primary care. And support is given by local alliance teams around the rollout of those tools, but it requires obviously scheduling of work in a different way. So it's not just the tool, it's the support to the practice, and also around the public engagement with that. So we continue to work on that. Optometry and pharmacy, really good take up around pharmacy first. I think we'll see that as a really good tool across this winter, where we're above 95% sign up for our pharmacies around the pharmacy first approach, 10 minor ailments that can be treated in pharmacies that is having national awareness, but we continue to reinforce through our local comms camp with our comms leads there. Alliances continue to develop integrated neighbourhood teams, and the raising of awareness of that within the financial recovery programme is important, because it does support the conversations we've had today around flow, early intervention, expedited discharge, and utilising the community services in a better way, and raising the simplicity of getting to those from ward-based care to discharge, which, you know, we can't assume everybody knows everything about everything in the community. We need to make it very transfer care hubs of the tool to do that. So all alliances have implemented those, and they're maturing, I think it's safe to say, but we seek to continue to mature those through the winter period, given the scenario that Jen's just demonstrated to us around finances. There is also note within the paper around the Better Care Fund, which is signed off with no escalation issues currently with all our local authorities, upper tier local authorities. And I think the finer details within all the alliance groups, which I'm happy to take any questions on behalf of my colleagues. I think that's probably as much as I should give you right now, given the time. But alliance delivery plans are being replicated across all of the 4 places to relate into financial recovery, as well as system flow and the development of the integrated neighbourhood teams. That's as fast as I could.
Well done, and thank you, Pam. I mean, there were some of us who had a detailed presentation on what's happening in our patch in dentistry for another purpose, and we were told by the regional dentistry director it's exceptional, and it was exceptional, and it was a delight to hear, because there is innovation taking place. These are at the moment of the nature of pilots, but it seems to be going sufficiently well that these pilots will, I'm sure, turn into actuals, whatever what's a grown-up pilot
Business
look
as
like?
usual.
Business as usual. Thank you. Thank you for that elucidation. Right. So these pilots will grow up into business as usual, and it's really good to see that, because we were, well, I certainly for one was anxious when dentistry was devolved that, you know, we would be powerless to improve things, and yet actually we've taken a grip and done something. So I think it's really, really pleasing work, and our thanks for that. And there's lots of really good things in the report here. In the same sort of vein as dentistry, optometry, I know, thanks to Shaheen, has been working with our hospital and colleagues there in this kind of what I would call as an outreach sort of model into optometry. I think there's another conversation, a bit like the conversation where we might be in competition with local authorities for, and therefore paying extra money when we're short of money for the provision of services. We need to have that conversation, I think, in the ophthalmology commissioning area, and maybe we need to get a conversation set up with Shaheen around all of that to see what could be done, because with the shortage of money, any savings, look, I made Jen smile for a moment there, would be a good thing to achieve. An encouraging report. Any questions or comments? Jeffrey and then Shahina.
Yeah, thank you, Pam and Dan as well, and Anna for the report. Always very informative as always. And I think one of the things I also need to comment is really good to see the progress on the integrated neighborhood teams. And I haven't seen everywhere, but I've seen in quite a few places, and we should be really proud of the progress and the speed we are making and how well we are doing, just to add to what the chair was saying on the other activities. I think my comment is around, and Chair, I'm very excited, potentially very excited, I think I should say potentially, on the thriving places concept. And can you just say a bit more about, because I see it involves the local authority partners as well, being part of that process. How do we select these thriving places, for example? What's the kind of criteria we do that? And do you think that it's got some role to play when we move along our prevention agenda, given what the current government is saying, given what we want to do around moving away from less in the acute and more in the prevention? Is there a role there? And I hope not next year, but soon, we could be spending less money on the acute and more in this kind of activities. Thank you.
Pithy snapshot replies.
I was going to say, in the interest of time, Jeffrey, it's probably best if we pick it up outside, come along and visit the people doing it. In terms of what they measure, it's multifactorial, many different things. And the real, I guess, brilliant thing about it is it places the control nearer to the populations themselves to self-determine. But rather than go into the detail of it here, definitely come out and visit.
That's an invite. No one can turn around. Go and visit a thriving place.
Yes.
Thank you, Jeffrey. Shahina.
Thanks, Pam. I'm also excited about enabling independent prescribers, because if we get that sorted out, we'll be first in the country to be able to do that in the community properly. So more than happy to help. I know it is tricky, but I'll help.
Thank you. Peter, and then Dan, and I'll be starting to close up.
Just on the transfer of care hubs, recognising it's early days and some positive signs. I see Thoric Health Watch did a piece of work to kind of gather views from professionals and from patients about the experience. I just wondered if we could do something similar, even if it's just light touch in Essex as well, to get views of workers and patients.
Yeah, absolutely. I think Mid Essex has done a similar sort of soft data capture around their transfer of care hub and of starting that. So I think if we work with you and the local alliance social care leads as well, then we could start to bring that together. Thank you.
Okay, thank you. Dan?
Just a small thing, Mike, and Pam referenced the change in premises directions, and it's more for you, but also to pay credit to Jen's estates team and the finance team that have supported. Since the premises directions have changed, we have managed to unlock Section 106 in 3 or 4 areas, albeit in areas where there's little or no
long-term revenue impact, but it does mean that we are now starting to get some traction on Section 106 schemes. And I know you've had people in your ear on that front. So I think 3 or 4 to date, primarily in mid-Essex so far, but I know my other Alliance colleagues are following suit. So it is progress. It's not the floodgates, but it is progress.
Excellent. Joe's got in under the wire.
Thank you, Chair. Appreciate it. It's a small point. Happy to take it offline, Barry. But I notice in all the good work we're doing with cloud-based services for GPs, we seem to have an interoperability issue. And I'm curious about that. We don't need to answer it now, but is there a way through that, or should we just chat offline?
Happy to pick, in the interest of time, happy to pick the conversation up offline. Otherwise, we're going to the detail, I think.
Okay.
Yeah.
Thanks, Barry. Cheers.
Thank you. So we now go to the board assurance framework. Tom?
I think the paper is self-explanatory, Chair. I think just the one thing to note is there's some work going on the risk hierarchy at the moment, which will be coming through to the executive team for approval, taking account of the National Quality Board's proposals around how we can improve risk management in the context of complex system risk, which is obviously what we deal with. So there'll be a board seminar on that, but the BAF's here in its current form for noting.
Okay, well, we look forward to the seminar on that, which I think is a good place to give it the airtime it deserves. We've got some revised policies which are there. I hope you're happy to support them. They've been through the appropriate committees where necessary. And we've got the approved committee minutes, which are really there for information, unless on any occasion one of the chairs wanted to escalate anything, and I haven't been let know that that was the case. And I've not been notified of any other business. So regrettably, 3 minutes late, we come to the end of the first part of our meeting. So there'll be a small 5-minute pause. We say thank you to members of the public who've joined us today. Thank you if you've joined us online, so to speak.